Hi, this is Brian Kim. I'm going to share with you case number 79 in the best way to do cataract surgery series. This patient has a pretty severe Bell's reflex, and I'm going to show you instead of using forceps, instead of using a Thornton ring, those types of instruments, you can accidentally scratch the corneal epithelium. The patient suddenly moves and it can be uncomfortable. And so this is a pretty easy and simple technique, which I call the Cannula Oar-Lock technique. And so I'm using a cotton tip to center the eye, and then using the corneal marker to help me center and size the rexus. I'm making my paracentesis incision first on the right side and then the left side, making sure the incision is parallel to the iris plane so I can achieve a corneal shelf and a self-sealing corneal incision. So this is a patient's left eye, and you can see that the eye is turned all the way to the right here. I injected some intracameral lidocaine and then now some dispersive viscoelastic. And so again, the eye is being turned up again, which is the left eye. But look at this, I'm going to rotate the cannula almost perpendicular to the direction of the incision. And this is the Oar-Lock technique, and I'm able to turn the eye back downward towards the left. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter and then dive down. And so using the Oar-Lock technique, I'm able to center the eye. It's much more controlled. There's no major stria in the cornea. Again, I'm not having to hold the eye, which the patient might feel, and it can cause discomfort. If the patient suddenly moves, it can scratch the cornea. And that's the reason I never really liked the Thornton ring when I used it in my training. And I don't like to use the forceps as well, because you can grab the cornea or the conjunctiva and get a conjunctival laceration or corneal abrasion. You can see using the Cannula Oar-Lock technique, I'm able to just rotate that cannula and I'm able to achieve a pretty nice, well-centered and sized rexus in the process. And this is a capsular fornix hydrodissection technique. I place the cannula underneath the rexus edge contra-incisionally, point the tip down, get a nice fluid wave, decompress the lens, spin it on the left side, and then turning the cannula to the right, pointing it down, and the lens spins freely. I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material, place the chopper underneath the rexus edge. Rotate the phaco tip vertically subincisionally, bringing both instruments together and crushing the lens in half. That's the double chop. Placing the chopper around the right heminucleus, pulling it centrally, bisecting the right heminucleus. That's the cross chop. Lifting that first quadrant up with a little bit of vacuum, crushing it between the chopper and the phaco tip, and emulsifying it. Hooking the second quadrant up with a chopper, pulling it up, and then crushing it, and then emulsifying it. Rotating the second heminucleus in front of me, placing the chopper around the lens, pulling it centrally towards the phaco tip, crushing it and dividing it, and doing the same maneuver for the third quadrant, and then here for the fourth quadrant. Now all the endonucleus has been removed, and I'm carefully removing the epinucleus from anterior to posterior, and it prolapses out very nicely. I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. I'm starting subincisionally, grasping the anterior aspect of the cortex and peeling it from front to back. And then switching to polish mode, polishing underneath the rexus edge and underneath the pupil edge as well. Even though this is a blind sweep, because of the polymer tip as well as the low flow settings, this is a very, very safe maneuver with the polish mode. Now I'm polishing the posterior capsule surface of the wispy cortical material as well as underneath the rexus edge. There's some just fine, stubborn, wispy material still adherent to the posterior capsule surface, which I'm just carefully trying to remove. Polishing underneath the rhexis edge again. It was a little bit sticky, so I switched to the cortex mode, and then I'm switching back to the polish mode. Sometimes the cortical material is fairly adherent. Now that this is done, I'm going to place a cannula through the paracentesis and pulse BSS into the subincisional capsular fornix to see if there's any cortical material. I happen to be clean here. Now I'm injecting some cohesive viscoelastic to fill the capsular bag. And then I'm using the capsule sweep to polish underneath the rhexis edge on the left side here first. And then on the right side. This is a 3-piece lens, so I'm going to widen the incision with my diamond blade. I'm going to inject the 3-piece lens into the capsular bag, pointing the barrel to the left. I'm delivering the leading haptic, which comes out pointing to the left. Place it into the capsular bag. As the optic is delivered, you want to turn your hand, the barrel of the injector, counterclockwise so the optic comes out planar, as I'm doing here. And then you want to sweep the trailing haptic to the right. And then I use a Maltzman to dial the trailing haptic into the capsular bag. Okay, go in with irrigation off, activate irrigation, go under the lens, remove all the viscoelastic from within the bag. Reposit the lens back in the bag, remove the viscoelastic from the anterior chamber. There is some fine material still attached to the posterior capsule, so I switched to polish mode, and I'm polishing a little bit more. And then when I'm done with that, I switch to visco mode again, removing the viscoelastic from the anterior chamber, and then I hydrate my incisions. So again, this is a patient with severe Bell's reflex, and if it was the right eye, you can just place a cannula there to prevent movement towards the left. However, this is a left eye, and so it's going to be moving away from my paracentesis incision. There's no easy way to hold that with the exception of trying to grab it with forceps or using a Thornton ring. So this is kind of my technique that just kind of discovered while doing the procedure is, normally Oar-Lock is something we don't like to see during surgery, but you can actually take advantage of the Oar-Lock phenomenon and rotate the cannula, which locks it in place, and you're able to rotate the eye downward, again, towards the left. I was able to make my incision as well as do my capsular rhexis and control the eye using the Cannula Oar-Lock technique. So I hope this was helpful to you, and I thank you for your attention.